Neuroanesthesia, and subject is anesthesia in patients with Huntington's disease. We will touch many points from this disorder like definition, pathophysiology, of course symptoms, and possible treatment. And the last line will be anesthesia and specificity or particularities. So let's start with definition. Huntington disease is a neurodegenerative disorder affecting central nervous system that results from an autosomal dominant mutation in the Huntington gene. It is characterized by movement and psychiatric disorders as well as dementia and occur in 4 to 10% in 100,000 of population. Due to the mutation of chromosome 4, which result in production of an abnormal form of protein called Huntington. The mechanism by which the genetically altered protein induces the associated central nervous system changes is unknown, but prevailing theories suggest that Huntington deposition enhances neuronal susceptibility to oxidative stress, very important, or glutamate-mediated excitotoxicity. The brain undergoes progressive atrophy and gliosis. Next one is pathophysiology. Atrophy and gliosis that is most prominent in the basal ganglia. Striatal atrophy becomes apparent with some MRI techniques more than a decade before onset of clinical symptoms. So if you are doing MRI by chance without having any symptoms, you can detect it if you have, of course, Huntington disease. Cerebral alterations combined with loss of GABAergic neurons in the striatum and skeletal muscle changes help explain the motor symptoms of Huntington's disease. A patient with Huntington's disease can develop symptoms at any time after infancy, but they usually become evident in the late 30s or early 40s. Genetic testing now allows for earlier diagnosis and the option of genetic counseling. Let's discuss motor symptoms of Huntington's disease. So, lack of coordination and involuntary jerk. Involuntary correct movements, an example, random jerking movements of the extremities, of the torso, face, and truncal muscles. Atetosis, which is slower sinusoid racing movements, and it peak after steady progression for 10 years and ultimately develop a rigid dystonic character. Dysphagia is common in advanced cases, and most patients suffer from malnutrition at some stage. All patients with Huntington disease eventually develop dementia. So that spares long-term memory, but impairs executive function, daily life function. Other psychiatric and cognitive changes occur before, after, and at the same time as motor abnormalities, and may include irritability, apathy, emotional instability, impulsiveness, and aggression. Depression is frequent, as is suicide, which occurs at a rate of up to 10 times that of the general population, and death usually occurs within 20 years of diagnosis due to falls, pneumonia, aspiration, malnutrition, and of course suicide. Is any treatment for Huntington's disease? There are are no specific treatment to prevent, cure, or slow the progression of Huntington disease. Symptomatic therapy aims to control the motor and psychiatric aspects of the disease. Drugs that shows in clinical trials to be efficacious for the treatment of chorea include amantadine, remacemide, levetiracetam, and tetrabenazine. They can cause some side effects like bradykinesia, rigidity, depression, and sedation. So, prudent anesthesiologists will therefore be vigilant for the possibility of adverse drug interactions. Because patients with Huntington disease are at increased risk of pulmonary aspiration due to pharyngeal muscle abnormalities and dysphagia, aspiration prophylaxis and precautions seem warranted. One of them could be administration of the gastric content decreasing like H2 blockators or proton pump inhibitors. Patients with Huntington's disease are also alleged to be at risk for prolonged respiratory depression and delayed return to consciousness after general anesthesia, and have reduced requirements for drugs, especially GABAergic. Whether this is related to the altered pharmacokinetics due to nutritional depletion and altered protein binding, increasing central nervous system sensitivity, or altered pharmacodynamics, it is unknown certainly. In any event, most patients with Huntington disease experience a normal anesthetic and post-anesthetic course. There is increasing incidence of abnormal plasma cholinesterase variants amongst patients with Huntington disease, and some cases can be reported with prolonged muscle relaxation following administration of succinylcholine. There are also reports of clinical significant generalized tonic muscle spasm related to shivering during emergence from anesthesia and especially in patients with Huntington disease, suggesting maintenance of perioperative normothermia, especially important in these patients. Some of the authors even recommend avoiding inhalatory anesthetics to decrease the risk of so-called post-operative shivering. Lastly, other than being technically difficult because of the continuous uncontrollable movements, there appear to be no contraindication to regional anesthesia in the patient with Huntington's disease, and it should be taken in account. Thank you very much for your watching. Have a nice day and subscribe if you like these videos.